I would like to introduce our next speaker. His name is Dr. Ayaz Jameel Ansari. He's a very famous physician residing in Bhiwandi, practicing since many years. I've known him personally. I treat him as an elder brother, and he has helped me a lot in establishing myself in Bhiwandi. Okay? Please, kindly come, sir.
Assalamu alaikum and good afternoon, everybody. Thanks, Dr. Bilal, for your kind introduction for me. And it was indeed a very good and very simple way of teaching and simple way of giving introduction of oral semaglutide. So I would like to thank all the doctors, those who have come here. And at the outset, I would like to thank Novo people for giving me this opportunity to talk on the oral semaglutide. As the already introduction has been given and spoken by Dr. Bilal regarding the use of the oral semaglutide. Oral semaglutide, actually it is a GLP-1 RAS analog. So first of all, we should understand what it is. Okay, so this is the one kind of anti-diabetic as well as anti-obesity, or this medication is used for the reduction of obesity. Few years ago, we used to have injections for this. So there were available injections, and those were misconception by few of our colleagues that once I have started injection liraglutide, that is injectable GLP-1, and one of our doctors said that this is insulin. So this is not insulin, and because of the daily injections, the new innovation, that is oral GLP-1, and that is oral semaglutide. So I will take you through some clinical experience. So we'll be dividing into the 3 patients. So first of all, I would be talking about the one patient who is a recently diagnosed and having low cardiovascular risk and having normal BMI. So one of our patient, her name is Varsha. She's 35 years of age and she's executive, and her BMI is around 23 kilogram and waist circumference is about 82 centimeter. A1C is around 9. Comorbidities, there is no. She is not having hypertension. She is not having any cardiovascular events or cerebrovascular events, or neither CKD. What medication she is on? She is taking metformin 500 milligram BID, and she is having sedentary lifestyle. Father was diabetic and he died at the age of 58 years from stroke. So she started lifestyle modification 6 months ago. What would be the concern? HbA1c, of course, it is out control because she is having lifestyle modifications and using metformin 500 milligram BID. And concern on putting weight with anti-diabetes medications. These are the concern. So remember this slide and remember the patient. What can be done in this patient? Because she is not having HbA1c under control. Remember one thing, we as a Indian, we are known as a carb eating countries. And also, we also known as thin fat Indian, lower lean body mass with higher subcutaneous fat. That is, अपने पेशेंट्स का या हमारे लोगों का उनका पेट या तोंद है, लेकिन जब आर्म्स की बात करें, बाइसेप्स की बात करें, मसल्स की मास की बात करें, तो उसमें नहीं है. So these are called as a thin fat Indian. 32% of Indians have normal weight obesity. So this is called as, just I have told you, we are having thin fat Indian. So 32% of Indians have normal weight obesity, and the thin fat phenotype experience the adverse complications at a lower body weight. And so therefore there is an increased chances of diabetes, hypertension and dyslipidemia. What are the increased abdominal obesity complication or health risk? If we have increase in the abdominal obesity, there will be mortalities, there will be cardiovascular death and diabetes, cardiometabolic risk, hypertension, risk of congestive heart failure, and atherosclerosis, risk of liver diseases. This all will be increased. Remember this thing, this is because of abdominal obesity, not because of diabetes. And again, as diabetes is a risk factor for all of these complications, Also, there is an increased risk factor, health risk of increased abdominal obesity. So, what is our duty? What is our aim? Our aim is treating early, it prevents long-term complications. So, intensive treatment for newly diagnosed patient, it is necessary to avoid long-term risk for diabetes complication. So, there is 1% reduction in HbA1c immediately after the diagnosis of diabetes. It leads to sustained reduction in the risk of complications. It means this patient is recently diagnosed, and if we try to reduce the HbA1c by 1%, so we will reduce the myocardial infarction by 20%. Intensification of the treatment and intensification of the reduction in the HbA1c. Also, if there is delaying the imposition of 1% lower HbA1c until 10 years after the diagnosis of diabetes, if we continue like this for around 10 years, so there will be several fold lower reduction in the myocardial infarction as well as all-cause mortality, as well as all-cause mortality and hospitalization of our patients. So early initiation of oral semaglutide within 1 year of type 2 diabetes results in a high proportion of patients achieving near normal HbA1c. What we have found out that we have started medication of oral semaglutide, and we have found that 45% of our patients, they achieve the HbA1c. So if we reduce the HbA1c, it means you are delaying the complications and you are extending the life longevity of our patients. See here in this slide, early initiation of oral semaglutide, 8 out of 10 people, they achieve targets. And in post-HOC analysis with the baseline HbA1c of more than 9, oral semaglutide resulted in the HbA1c reduction up to 2.6%. That is very significant. Here, as Dr. Bilal has already shown us the Pioneer trial slide, so we have divided these slides into the 6 points, 1, 2, 3, 4, 5, and 6, and 7, 8. Here we have used liraglutide, that is the injectable GLP-1. We have used sitagliptin 100 mg OD. We have used empagliflozin 25 mg OD, that is the SGLT2 inhibitors, and also placebo, as well as oral semaglutide 14 mg. So here you can see we have found around 2.6 reduction. That is quite significant. And also semaglutide, it reduces the calorie intake, and total daily energy intake was significantly lower with semaglutide than with placebo. It means after using the oral semaglutide, there is a reduction in the calorie intake. 35% reduction in the energy expenditure. So main aim of the GLP-1, what it does actually, they are called as a glucagon-like peptide. What they do, they increase the secretion of insulin from beta cells, and also what they do, because there is a glucose in our body which is produced by liver. Therefore, our blood glucose level tends to rise, and co-interact, we are having insulin. So what this GLP-1 or semaglutide does, it increases the secretion of insulin from beta cells, as well as it inhibits and it reduces the glucose production. So what we are doing, one side, we are decreasing the blood glucose level, and another side, we are decreasing the production of the glucose. So we are achieving multifactorial facets. So semaglutide, it is having a less appetite and food cravings, better control of eating, lower relative preference for fatty and energy dense foods. And one more thing the semaglutide does, it decreases the waist circumference. It decreases the waist circumferences alone. And if you use it with empagliflozin, that is SGLT2 inhibitors, so what we have found that there is a significant weight reduction, about 3.7. Okay, and if we use with semaglutide along with sitagliptin, we have seen around 2.3 centimeter of weight in the waist circumference reduction. The oral semaglutide actually it exhibited better time in range, and it has the greater time spent with HbA1c less than 7% with oral semaglutide versus oral comparators. So this is a very significant reduction. So we have already spoken about the patient one. Remember the Varsha, 35 years old, 9 A1C, no comorbidities. Now I will take another patient of mine. Okay, and he is having diabetes along with atherosclerosis, cardiovascular diseases. His name is Deepak, 47 years of age. BMI is very high, around 30. A1C is same as Varsha, around 9. And he is having hypertension, dyslipidemia, and obesity. And if we talk about medication, he is taking metformin 1000 milligram BID, glimepiride 2 milligram OD, and sitagliptin 100 milligram OD. History, he is a very active smoker and also having sedentary lifestyle. So what would be the patient concerns? Uncontrolled A1C, levels despite polytherapy, he is using combination pill, and weight uncontrolled by lifestyle modifications, and dosing schedule of multiple medication, concern about possibility of starting insulin, and of course cardiovascular risk factors. So this is our another patient. First patient we have discussed, and how to use the semaglutide. Now this is our second patient. He is having comorbidities such as hypertension, dyslipidemia, and obesity. So what is our aim and what is the importance of the multifactorial therapy? Early multifactorial therapy, it reduces the risk of complications in people with type 2 diabetes. So what should be our aim? Our aim should be, and the using of multifactorial therapy or combination pills would be, there must be a good glycemic control, lifestyle modification, weight management, and it has to be BV lower category as well as dyslipidemia control, and of course there is a platelet inhibition. I will take you to the few years back. Then we were using a traditional treatment for diabetes. If the patient has got diabetes and diagnosed diabetes, our aim was first traditional, which ADA, American Diabetes Association, used to say, use diet and exercise, metformin, then adding of SUs, sulfonylureas, then adding of AGIs, then adding of thiazolidines, then adding of DPP4, then adding of SGLT2, then adding of GLP1, then adding of insulin. So this was the traditional treatment of diabetes. But since 2020, actually we used to practice before that, since 2015 and 16 only, we started our patient with the combination therapy. So this was not in the guidelines, which came into the guidelines in ADA 2020. So that's what it is very important, because if the patient is having HbA1c 9, fasting is around 250 and PP is around 400, we shall not start metformin. We have to intensify, because we want to see the patient to prolong his complications for beyond years. Suppose if the cardiovascular complications yet to come in the 2024, our aim is to extend beyond 2030, beyond 2035. That's why it's very important. Early intensification of the treatment of diabetes. So if we consider this, we achieve the targets, decrease in the mortality around 45%, survival would, our patient would be increased by 7.9 years, and time to first cardiovascular event, it will increase. That's what I told you. Suppose the patient is yet to get heart disease due to diabetes in 2024, but he will be having this after 2032. And as well as microvascular complication, the reduction about 48%. So this must be in our mind and our aim. So if we choose the right anti-diabetic, of course we consider this all these sentences. We are having GLP1, SGLT2, DPP4, insulin. Our aim, the patient should not land in the hypoglycemia. It must be having pleiotropic benefits, and the cardiovascular risk factor reduction must be there. And of course, there must not be increase in the body weight. Either it must be neutral or there is a decrease in the body weight. And of course, it has to be a very good glycemic control. So by these points, what we have seen that GLP-1 RAS analog, they all fulfill this. And especially the lower risk of hypoglycemia. Remember, hypoglycemia, it is a very dangerous than hyperglycemia. Okay? And the semaglutide addresses mediators of atherosclerosis, cardiovascular disease, and it is very suitable once a day Oral semaglutide reduces systolic blood pressure by offering a reduction of 1 to 6 milligram HB. Okay. So there is 11% for any complication related to diabetes, 16% for death related to diabetes, 11% for myocardial infarction, 10% for microvascular complications. And also it improves the blood lipids and with reduction in LDL and triglyceride level. So this is indirect effect of oral semaglutide. It also having anti-inflammatory effect and ongoing cardiovascular outcome trials of oral semaglutide in patients with type 2 diabetes. There is a one trial. We have taken around 9,642 patients having more than 50 years of age, and they are having cardiovascular and CKD events and HbA1c more than 6.5 to 10%. And the primary endpoint was cardiovascular death, non-fatal myocardial infarction or non-fatal stroke or major cardiovascular events. And the secondary confirmatory, it was composite CKD endpoint consisting of cardiovascular death, renal death, onset of persistent more than 50% reduction in the EGFR, onset of persistent EGFR less than 15 ml per minute, 1.73 meter square, or initiation of chronic renal replacement therapy and cardiovascular death. Composite peripheral artery endpoint consisting of acute and chronic limb ischemia hospitalization. So main thing is it has the ability to reduce and also help in the renal modulation. So we have spoken about two patients. Now I will talk about my third patient. So this patient, it is very complicated patient and he is having multiple problems and multiple comorbidities. He is Dhanashekhar, 67 years of age, BMI is around 21, A1C is 12, EGFR is around 30, serum creatinine is around 1.8. He is having hypertension, he is taking ARBs and diuretics, dyslipidemia on statins, also CKD. Remember, in previous our patient, he was not having CKD. And he is taking linagliptin 5 mg OD, empagliflozin 25 mg, and also he is using insulin degludec aspart 15 unit 2 times. Smoker, and he is also suffered stroke 7 years ago. So what would be the patient concern? There is reduced sleep, generalized weakness, swelling of both legs, occasional feeling of giddiness. So remember, this is our third patient. He is 67, so he is old. Previous patients, one of 47, one of 35 years of age. So this is very complicated patient. The care of this patient, it will require nephrologist, endocrinologist, diabetologist, cardiologist, and of course a very good hospital. So patient preferences, comorbidities, kidney function and cost impact, selection of glucose lowering treatments. In this patient, cost would be at very higher side. Remember the cost of the medication nowadays, though it has come down a lot because before times we used to have 45 rupees a tablet of DPP4 inhibitors. Now we used to get at 10 rupees at par. SGLT2 inhibitors 2 years ago we used to get at 55 rupees a tablet, but now we are having just 12 rupees apart. Even after that, we are having a lot of economical burden on our patients. Why? Because once a patient landed in diabetes and which is uncontrolled, at certain time and early and very fast, he will end up either in the cardiovascular events or he will end up in the any cerebrovascular event. Remember one thing, in our family, a single person is suffering from stroke. He is having left side hemiplegia. He is having paralysis. Upper limb and lower limb is not working. Now think and see the patient and remember one thing. Just imagine this patient. What would be the condition of the family? There would be stress. There will be economical burden on the patient. That's why it's very important to intensify the treatment of diabetes, because we should prevent these kind of things. And at the very early stage, by intensification, we can achieve this. So in this patient, GLP-1 RAS analog have a well-established safety profile with no need for dose adjustment in people with diabetes and CKD. So we can use oral semaglutide in these patients. And of course, there is no dose adjustment is required. It also provides robust glycemic and weight reductions in people with type 2 and CKD, as we have seen in the Pioneer trial. We have seen there a reduction of the weight around 3.4 kgs. So GLP-1, it has the cardio-nephroprotective outcomes through indirect and direct mechanism. So what is the direct mechanism? Direct mechanism, it has the ability of natriuresis. There is an increase in the natriuresis, and there is a reduction in the kidney and systemic inflammation, which reduced plasma levels of tumor necrosis factor alpha, and there is a decrease in the oxidative stress. What are the indirect effects? Of course, the glycemic control, there is a good blood pressure control, and the very important thing about weight control. So the semaglutide can be used in this patient. And semaglutide, it was associated with a significantly smaller annual decline in the kidney function compared with once we have done with placebo. What if semaglutide as add-on insulin? Of course, we are having a very good result and significant result with the using of insulin along with oral semaglutide. So, if we talk about the renal outcomes in combination therapy of semaglutide and SGLT2 inhibitors, so dual therapy with GLP-1 and SGLT2 when compared to the reference therapy, what we have seen that there is a significantly lower risk of end-stage renal disease and eGFR that decreases around more than 50%. That is very important because of the ability of renomodulation. And also it is having similar risk reduction seen for chronic renal diseases. So as we have already seen our 3 patients, so semaglutide can be used early in the course. Those patients are recently diagnosed, and early targets better durability. Type 2 diabetes patient, those are obese and those are overweight. So we are having a greater weight reduction. Remember one thing, it is 1 kg in the reduction of the body weight will reduce in the HbA1c. Therefore, that is termed as called as a kg-A1c. So, if you reduce a single 1 kg of your body weight, that will decrease the HbA1c. And remember one thing, that will decrease further more folds of cardiovascular events, CVA, CKD, and of course any cerebrovascular events. And type 2 diabetes patient with multiple comorbidities, CKD, CVD, metabolic syndrome, targeting multiple cardiovascular risk factors reduction. And if we talk about in long-standing type 2 diabetes patient, those are on insulin, there is a weight reduction and also having insulin benefit effects. So using of the oral semaglutide, though we can use it as a anti-diabetic, also we can use in obesity patient. By using this, we can achieve a very significant reduction in the HbA1c. That is our aim, just to decrease the all-cause mortality and just to reduce and prolong and extend our patients' coming complications from now to onwards. Onwards, it could be more than 5 years, 10 years, beyond 10 years. So that is our aim. Thank you. If any question to me and Dr. Bilal, we would be happy to answer, or any query from your side.
What is the cost of this medication? Does anybody know what is the cost?
Cost for this oral medicine which we have, it is available in 3 strength. Ribelsis 3 milligram, Ribelsis 7 milligram, and Ribelsis 14 milligram. तो 3 मिलीग्राम का प्राइस है 3170 रुपीज़ फॉर 10 टैबलेट. तो पर मंथ का थेरेपी जाता है अराउंड 9500 रुपीज़ विथ रिबल्सिस 3 मिलीग्राम. 7 mg का जाता है 10500 रुपीज़ एंड 14 मिलीग्राम का जाता है 11000 रुपीज़. तो डिस्काउंट करके पेशेंट को बेनिफिट मिल जाता है अल्टीमेटली, लेकिन 7 to 10,000 के बीच में आप पेशेंट को बोल सकते हैं.
अभी आप सब पूछेंगे 10,000 रुपये महीना कौन गलाएगा वजन कम करने के लिए, है ना? तो यही चीज़ आपको समझाना है सर ने और मैंने कि पेशेंट का वज़न कम करना सिर्फ एस्थेटिक्स के लिए नहीं कर रहे हो तुम, सिर्फ दिखने के लिए नहीं कर रहे हो। दिखने के लिए तो वो जिम भी जा सकता है, कुछ भी कर सकता है। उसका हार्ट, उसका लिवर, उसका किडनी, ये सब चीज़ों की कीमत है वो बचाने की, और उसकी ज़िंदगी ज़्यादा बढ़ाने की कीमत है ये। जब आप पेशेंट को समझा पाओगे कि इससे क्या क्या फ़ायदे हैं, ये सिर्फ वेट लॉस का मेडिसिन नहीं है। ऐसे तो कोई भी दे देगा ना कल को मेडिकल छोड़ के, ऐसे भी कोई स्लिमिंग सेंटर वगैरह ये भी लोग यूज़ कर लेंगे। तो दिस इज़ नॉट फॉर दैट, दिस इज़ नॉट फॉर एस्थेटिक पर्पसेस, दिस इज़ प्योरली फॉर मेडिकल रीज़न। और वो रीज़न आपको समझना ज़रूरी है, तब जाके आप पेशेंट को समझाओगे, तब पेशेंट खर्चा करने के लिए भी रेडी रहेगा। क्योंकि अगर उसको आप बोलोगे कि उसका हार्ट अटैक नहीं आएगा, 4 साल तक उसका हार्ट अटैक डिले हो जाएगा, तभी तो वो खाएगा ना। जब आप उसको बोलोगे कि उसका हॉस्पिटल का खर्चा बच जाएगा अगर वो खाएगा, तो तब वो खाना चालू करेगा। और याद रखिए, भिवंडी इतना भी गरीब शहर नहीं है। वी हैव इनिशिएटेड many पेशेंट्स हु हैव कंटिन्यूसली टेकन दीज मेडिकेशंस ओवर अ पीरियड ऑफ 3 to 4 months, और उनको रिजल्ट्स भी आया है। तो वी शुड नॉट थिंक, हमारा है ना सोच बदलना चाहिए कि भिवंडी गरीब है, कौन खाएगा, है ना, ये इधर से भाग जाएगा। नहीं, यू नीड टू कन्विंस देम। कन्विंस करने के लिए आप जब समझोगे तो आप कन्विंस कर लोगे, वो खा लेगा, उसको रिजल्ट आएगा, वो आपको बधाई दे के ही जाएगा।
एनी अदर क्वेश्चन? किसी को कुछ और पूछना है? सीनियर लोग? अच्छा, ठीक है। सो आई थिंक विद दिस we shall conclude today's meeting and today's CME. Indeed, it was very educational, and I thank Dr. Bilal, and I thank all the doctors for coming and attending this afternoon, and we will continuing this CMEs further. So with this, I close this talk. Thank you.